First, I want to introduce our lineup of speakers. I'm Dr. Jessica Evert, and I am a clinical professor in the Department of Family and Community Medicine at University of California, San Francisco. I'm also the Global Medical Director of Child Family Health International. I'll tell you a little bit about my story, but my research focuses on the pedagogy and ethics of global health immersion and experiences and global partnerships. So I'll turn it over to my colleagues to introduce themselves. Tricia.
Hi, everyone. I'm Tricia Todd. I'm the director of the Pre-Health Student Resource Center on the University of Minnesota Twin Cities campus. I have been here for 20 plus years, and I have a deep interest in this because years and years ago, I learned that students were going abroad and participating in activities that, with my public health background, seemed highly unethical. And so later I will talk a little bit about all the things we've done to try and address that on our campus. Shelley?
Whoa, there's a photo of me there. Hi, folks. My name is Shali Prasad. I'm the executive director at the Center for Global Health and Social Responsibility at the University of Minnesota. I'm a professor in family medicine and community health, and most of my work has been in health systems-based work, particularly in primary care around the world. And similar to what Tricia mentioned, and Jess is going to talk a little more about this, this is a issue that has been bothering me for a long time. Part of it is I've seen the effect of it in other parts of the world and how we should be very cautious about our work. So hopefully we'll talk more about that.
Thank you. And I just want to give a little more background around why I'm here. Over 20 years ago, as a student, I fell for a poorly designed international experience. And during that experience, I injured a child when I was encouraged to do a procedure, a spinal tap on the child, while a very capable local doctor sat next to me and multiple nurses held the child down. I did not successfully do the procedure. I delayed the child's diagnosis and I injured the child in the process. And as a student, I thought I was doing a really great thing being in East Africa. I was in Kenya and thought that I was doing a service. And it wasn't until later in my career that I realized what a disservice I was doing, both for myself as a student and developing myself and my values, but also for patients and for the global community. So I've carried a lot of guilt and remorse for that situation, but also a lot of compassion for myself as a student, and realizing that how I got to that position and how that all happened was a very complex matrix of intersectionality. And I've dedicated part of my career to understanding and educating on this phenomenon so that students and those facilitating experiences can be really thoughtful about how they're doing so and really align them with the values and principles that we want to have as physicians and healthcare personnel. I do believe in these experiences, so I've come full circle, and for the last 16 years, I've been working with Child Family Health International, which is a nonprofit that actually facilitates global health immersion in 10 countries. And so I do believe in them. However, there's a lot of caveats and asterisks involved. And so we're going to explore some of those today. I also want to name that I am getting the privilege to speak today, but really I'm representing a team who's doing the real work and are dispersed through 10 countries and our local community members, leaders, and dedicated to health equity and justice year round. So I am speaking on their behalf and grateful to be able to do that. So when it comes to undergraduates and pre-health students doing international experiences, they can happen under the auspices of many different paradigms. So these may be volunteer experiences, medical missions, internships, service learning. They may be research opportunities. They may be shadowing, studying abroad, capstone projects. There's a lot of different labels that these activities fall under. But the experiences that we're talking about today are any experience that places a student in a health-related setting abroad. And these may be public health settings, they may be clinical settings, often intersections of both. And that they are often constructed for the students' benefit in terms of their sense of service or their learning. and or may be happening within existing health systems. There's often kind of an assumption that the students are helping the communities they're going to, and we're going to talk about that assumption and the problems with it. But I just want to make sure that there's a broad umbrella of understanding of how many different experiences this can include. And I know that those of you that are here are probably have had some exposure to this. So feel free to put in the chat any questions or comments you have at any time. We are going to have discussion at the end, but I'd be interested in it if you had any other thoughts on experiences that you're seeing this happen in. One of the research projects we did was looking at pre-health advisors, because we realized, about a decade ago, that pre-health advisors were actually part of the dynamics here in terms of what they were telling students they should do to get into medical school or health profession schools, and also the advisor sense of what are standards of care in international settings and what actually impacts health outcomes. And so this study was in collaboration with the NAAHP, the National Association of Advisors of Health Professionals. And what we found is that 82% of pre-health advisors around the country encountered pre-med, pre-health students that were going abroad to get hands-on clinical experience. So when you consider the tens of thousands of pre-health students that exist, the numbers of students that are going abroad to get these experience on an annual basis is somewhere in the 10 to 20,000 number in the US. 88% of advisors were somewhat or very concerned about students getting these experiences abroad and what they were hearing students say they were doing. And then on the flip side, only a third of advisors felt comfortable and equipped to advise students who are seeking hands-on experience abroad. So it's kind of the perfect storm of advisors not feeling equipped, students seeking these activities, and advisors hearing about stuff they were doing that they were concerned about. Around the same time, the AAMC did a survey of medical school admissions committees. What they found at that time, and this is back in 2016, was that 50% of medical schools admissions directors said that they consider applicants' involvement in invasive procedures in international settings as harmful or of no value to students' applications. And 73%, yet at the same time, a predominance, and this number is more than 73%, I think now, highly recommend or require that applicants have had experience in which they are observing or learning about clinical experiences. And when we did a review of websites, we actually found that admissions websites for medical schools were often telling students to get clinical experience, get experience with patient care. And so we realized that students were getting these messages that this was necessary to get into medical school, but yet misinterpreting them and going abroad, facilitated by problematic organizations and doing things that were harmful. And of note, 50% of medical schools were being equivocal about if this was harmful or not. Then there was some pockets of increasing scrutiny of these activities. This is a medical school dean, and this was over 10 years ago, who they were holding their admissions committee responsible for vetting these experiences and actually deciding not to admit students when they had done problematic things when they were abroad and they didn't have insight into how problematic it was. And so we saw pockets of schools that were being quite savvy and really kind of having repercussions for students. At the same time, we've seen the rise of a field of practice called global health. Global health was formally defined in 2009, but basically you can see it as the rise of a field of study, research, and practice that's really trying to put more academic and evidence-based frameworks around what was prior called international health. And so the rise of global health as a field gave a gathering space for people who were practicing this in professional senses to come together and start to set standards of care, practice, and ethics. And the framework on the left-hand side is actually out of Canada, and it speaks to the competencies of global health practitioners and ways of developing that competency. But what I want to hone in on is those values and principles that are on that outside rung that is orange and purple. So there are values and principles that are essential to what global health is, which is basically health equity work. And those values and principles include things like social justice, solidarity, responsiveness and accountability, honesty and openness, humility, sustainability. And when we are looking at what pre-med and pre-health students are doing at undergraduate levels, they do not fall in line with these values and principles. And so a lot of students are getting experiences that are antithetical to the field that they're pursuing and their hopes of contributing to health equity. And concurrently, there's been a lot more data and work on a global scale of what actually impacts health outcomes and what we call the global burden of disease. So no longer is there kind of as much misunderstanding around what actually changes health status of communities. We know, and now it's a matter of actually applying that knowledge, which impacts how pre-health students are getting experiences abroad. So why are these settings unique? So the settings I'm talking about are in low and middle income countries generally. This also happens in resource deprived environments in our own country. But for the sake of this conversation, we're talking about students who are going international to the US, generally to Latin America, to Sub-Saharan Africa, to Asia, to indigenous territories, to other settings that are already resource deprived. And these settings are often lacking the resources to keep students within an appropriate scope of activity. They have bigger fish to fry. Patients and patient care and other things are more important and have to be prioritized. And so the rules, regulations, enforcement necessary to keep pre-health students focused on the appropriate scope of activities can be lacking. There's also documented injuries and adverse outcomes in these settings that we'll talk about. And there have been contemporary standards that are developed over the last 20 years, which we're going to go into. These are also unique because students have preconceived notions about their role in poor settings. And there's a lot of dynamics around why those notions exist that we'll talk about. And these are unique because there are still outdated organizations and outdated dynamics that are allowing students to do things that are illegal, harmful, and unethical. There's evidence, so Noelle Sullivan is an anthropologist at Northwestern University. And those of us that are presenting on this webinar used to think, well, if we just educate people, then they're going to do the right thing. If we let students know what they should be doing, and if we let organizations know and universities know, then it's going to go better. And fortunately, Noelle Sullivan's work, which took place in Tanzania, showed that even when students, pre-med students, knew what they shouldn't do, they actually proactively went around the regulations. So for instance, there was a obstetrician gynecologist who was in the labor and delivery ward of the hospital in Tanzania, and she would not let the pre-med students deliver babies or touch patients. And when she would leave, the students would text each other and say she has left. They would then go to the L&D ward, and the nurses and the midwives were left who didn't have the same understanding of what the students should or shouldn't be doing. And the students were allowed to touch babies and participate in deliveries. And they purposefully went around the regulations that were in place. So unfortunately, it's not so simple as just educating students and others in this environment. There's also important dynamics around colonialism, racism, differential treatment for the poor that are affecting why students are doing what they're doing. So this is a quote from a website of a poorly designed program provider. And I wonder, Tricia, could you read this quote?
Sure. So what amazes me too is how holistic this organization is. Each day of the brigade had a medical, dental, and gynecology component in it. Patients attended a community workshop that educates them about key health practices. We were able to suture a patient whose left hand got caught in between his horse and a fence. The brigaders also provided dental education and fluoride treatment to over 30 children during our pilot day. Truly, this organization empowered us to provide medical and dental services even in the most remote locations. Yes, there is so much more that needs to be done, but we will do the work of one brigade at a time until one day the communities we serve can thrive on their own. Many thanks to this organization for giving me the opportunity to go beyond my borders and touch lives in Honduras. it truly was the trip of my lifetime. Hasta luego.
Thank you, Tricia. So I want to ask everyone here, does anyone see any problems with what the student took away from this experience or what they did? This is a pre-medical student. Feel free to unmute or to type if you feel more comfortable.
I would like to just comment on the comment that Catherine asked us, are these students certified to perform these procedures? Even if they were certified in this country, and maybe Dr. Prasad wants to weigh in on that one.
I think, thank you, Tricia. I think there is the premise of certification, liability, credentialing. And quite often people are like, oh, I'm qualified in the US or I'm certified in the US. And where I'm sitting is 35 miles from Wisconsin. I don't have a license to practice in Wisconsin. What gives me the right to go to another country and practice because I have a US license, right? So that is that part too.
Yeah, and this is a pre-med, pre-health student. So no, Honduras would not be giving them a license to suture a patient. What other things what takeaway did this student have from this experience? Does anyone know anything about healthcare in Honduras and whether undergraduate students coming is important for communities to thrive? Jan, I'm looking at you.
Okay, if you're looking at me, well, I can make a comment from the beginning of the presentation that it's all student-centered, or completely student-centered. Nothing about the needs of the local population, how they are prepared to meet them, and what do they get from it. So I think this is very, very selfish. And what's the benefit to the local population?
Thank you. And I would even say that the sense that the local population can't thrive on their own or isn't thriving on their own is also, you know, not accurate and generally is not the takeaway that the local community or those working there would want. So there's been a lot of harms to patients that have been documented in these programs, including pulling on breech babies, which has caused asphyxia and death. Patients not diagnosed with malaria when undergraduate students were put in charge of reading slides, giving the wrong dose of medications, not following up. There is also positive things that can result when experiences are appropriately scoped, which includes cultural fluency, humility, increased understanding of social determinants of health, appreciation of low resource care, intersections of public health and clinical medicine, the role of health, healthcare, and societies, rural-urban comparative, language acquisition. There's a lot of positive outcomes for the student that can happen during these types of experiences. In terms of Jan's question or comment on what are the outcomes for the community, there are not a lot of evidence-based outcomes that undergraduates going abroad change the health status of the community. What research has found is that the students improve the English proficiency of those they come in contact with. They increase the prestige of the centers and institutions that they visit. They increase the sense of local community members being able to fulfill their own sense of global citizenship and impacting students from other places. They increase the movement of resources that are attached to the student, whether those are financial, material, or immaterial. And they increase the ability of local people and institutions to build networks, which are also often involved in facilitating these experiences. So the outcomes are not evidence-based to show that they change health. So back to the student and what the problem is. This problem starts before the student even goes abroad. This is an example of two different websites talking about the same place, advertising experiences to students. One organization tells the students, in Bolivia, people live in extreme poverty, unable to meet their basic needs. You can help by volunteering and providing essential medical care where there is none. Make an impact today, no experience required. The other organization says to students, The plurinational state of Bolivia's healthcare and economic sectors have celebrated many recent victories, including the adoption of universal healthcare in 2019, expeditious and thorough rollout of COVID-19 vaccines and supplies, and significant poverty reduction. Embed yourself in Bolivia's health system to witness local professionals' provision of care despite resource constraints, propelled by a health as a human right framework. So the students, even when they're getting sold, which a lot of these are paid experiences, these opportunities, they are extremely different messaging of those that are appropriately designed and those are inappropriately designed. Tricia, do you have any thoughts on these different messages that you see students getting?
Yeah, when you look at these and you think about it from the student perspective, you know, they look at that one on the left in Bolivia and it hits them emotionally and they say, I can help. I can help. The second one is focused much more on, I can learn. And they aren't as interested in the learning, sadly enough, as they are in the helping. And they don't recognize that the learning is the precursor to being able to help. And so I think the way these different organizations promote what they can do is part of what we are fighting against, because they're hitting students where they are being told, you know, yes, you can come help, when they really aren't qualified to.
And when we think about the dynamics that underlie this, there's a lot of them. So professional school admissions are a big motivator. Students are doing this because they think it's going to help them get into medical school or other health profession schools. But also there are the currents of colonialism, racism, differential treatment for the poor. There's deficit-based narratives. So psychologically, and there's another webinar in a few weeks about the psychology of this if you want to learn more. But psychologically, when we see a place that looks very different than what we're used to seeing, problems and what we perceive as problems will jump out at us. And our culture, many of those that are raised in the US, the culture is task-oriented. And so we want to jump in and do a task, and we think we can help, and we have an outsized sense of superiority and agency in settings that appear poor. When really in settings that appear poor, there's many, many things that are going well. There's innovation and resourcefulness and a lot of things that are happening in a sustainable way to impact health. Also, there's outdated incentives. So there's payment schemes and other incentives that are happening that enable students to do things that they shouldn't be doing. The myopic notion of health, so focusing on clinical care, when the determinants of health, like the social determinants, are actually much stronger than clinical care in many settings. And the limited expertise of faculty and mentor in home institutions that also enable students to have an unauthentic understanding. This is really the perfect storm, and this is only part of the storm, but there are also power imbalances and privilege imbalances between those who are visiting and local communities, but also power imbalances in the healthcare settings where patients are not able to ask, who is this person? Do they know what they're doing? There's the rise of chronic disease, but also the realization that even infectious diseases like malaria and HIV require longitudinal continuity of care. So this parachute in duffel bag medicine is outdated. We know that medical errors cause problems. They're the third leading cause of death in the US. These are high-risk environments. Even aspirin and Tylenol can cause problems. So handing out any kind of pills is not benign. There's organizations that will provide students with the illusion that they are a quick fix and this is appropriate. Students are highly motivated and driven and wanting to help and see themselves as an immediate solution to complex problems. And then there are easily ignored health systems that look very different from what students used to seeing. So those people in the bottom left image are community health workers, which is an essential primary healthcare infrastructure in many countries. But if students aren't told about it, if they aren't oriented to reality, they're going to drive by these folks and discount what a role they're playing. And so they will ignore existing health systems because the organizations, faculty, or professionals they're with are not giving them an appropriate version of reality. So how would students know what they should and shouldn't be doing? So over the last 20 years, there's been a variety of standards and advice that have come out towards students, both undergraduate, graduate, postgraduate students, and even professionals in this realm. There are standards by the Forum on Education Abroad, which is supported by the Department of State. The AAMC has standards. There's research in this area. There's work that Tricia is doing that she's going to talk about. So there are a lot of ways that students get this information. Similarly, the organizations that are involved in facilitating poorly designed international experiences also should know there's peer-reviewed competency goals that orient these experiences around appropriate competency development. There's local law and regulations that exist, but they're ignored. There are national and international standards. The organizations have actually gotten savvy where we have reviewed them, and they will use language on their website that says that students are doing things that are ethical and this is sustainable. But when you look at the content of their programs and you actually look at what students are doing, they continue to do things that are unsustainable, unethical, and illegal. This is big business. This is a multi-million, billion-dollar a year business. And it is based on providing healthcare and the sense of saviorism for Black, Indigenous, and people of color, oftentimes in low-resource communities, often those who are most voiceless, like women and children. And there are standards that exist to apply to these organizations. I'm going to have Shaylee speak to some of these activities and international collaboration that's happening around this area.
Thank you. Thank you for having me here. And it's been an interesting journey for me. And Jess and Tricia have been, code journey folks for me, sojourners in me in this field. Part of it is the bigger picture of what we think of global health, right? There is a hero complex that comes in. And it is sad. And I'm going to give you two quick anecdotes. One was in 2016. There was a young teenager in Florida who was arrested because he had set up a clinic and was billing Medicare for many months. And there was an outrage. He was arrested. People got angry, et cetera, et cetera, et cetera. Jess quoted Noel Sullivan, one of her friends who works at Northwestern in Chicago. She's an anthropologist, and she wrote a beautiful op-ed. This person who was arrested needed to be arrested, absolutely. But if the same person had gone to another country, we would have celebrated him. Look how great he is. Look how fantastic he is. I'll give you another contrast. My own university, University of Minnesota, is known for its hockey. We live in a cold state, right? We had a hockey goalie who apparently was one of the best college hockey goalies ever. She went to do medical care in Haiti, and she was celebrated. She won the Humanitarian of the Year award. ESPN honored her. She got into medical school based on that. Is that right? How is it that we accept double standards when, it's Haiti, so just because we have this humanitarian hero worshiping aspect in global health, is that the way we should be approaching it? So with that, I'd like to give you a few pointers here of our work too. Many of the activities in global health, particularly from the US, is around short-term engagements in global health. It's almost like a hobby, a pastime, a volunteer activity. There was once a cruise ship that would take you to the Dominican Republic and allow you to paint a school building to offset your guilt of having been in a cruise ship, because you're now a fantastic humanitarian, right? Can you imagine the number of quotes that school got? Thankfully, that is not existing anymore. Situations like this are rampant around the world, not just in the field of health, but it's more egregious in the field of health. In pre-COVID times, it was estimated that it's probably about a $4 billion industry from the US alone, right? We have data, it's not a great amount of data, that in a majority of these situations, they cause more problems. And to be honest with you, I would make a case that in a majority of situations, even when there are licensed providers from the US going, they cause more problems. There was a team out of Chicago that was sending surgeons to Bolivia. And after I'd given a talk, one of the ladies came to me and said they did an evaluation of their surgeons going to Bolivia and found out that the outcomes of surgery of the Bolivian surgeons was much better than that of the Chicago-based surgeons. And I'm like, great, what are you going to do about this? And her response was, not much. Our donors still want us to send surgeons to Bolivia. So we have this tendency of a very colonial approach, a deficit-based, and just mentioned this already, the deficit-based, oh, those poor people have nothing, so something, whatever that something that we do is better than what they have. And quite often, it's that ego stroking that occurs when one pats oneself in the back and saying, look how great I am in doing this. I had a physician from Haiti once ask me, I wonder if they'll allow me to go to the Bronx and start working with the homeless folks there. How is it different than folks from the US landing into Haiti, which has been called the kingdom of NGOs, to deliver rather haphazard care? Next slide, please. Besides ethical concerns, one of the main things that we're concerned in student-facing activities is this premise of social contract. The premise of social contract in medical education is that society allows learners to learn on them with an idea that it's an investment for the future. So when we send folks to our own neighborhoods to learn, hospitals around our university, there's an expectation that we are building the healthcare workforce. Are we doing a good enough job? I would make an argument, no. I'm a primary care physician. I would say we need more primary care physicians. That's for a different day. I would also make a point that the premise of social contract should be geocentric. We are not, or communities around the world are not there for our folks to go and quote unquote experiment or learn on. We can learn from the people who work there, but not learn on the people there. There are obvious legal concerns. Licensure, as I mentioned before, is a huge part of it. And we have data. Virginia Rothorn did a wonderful piece on this. Virginia Rothorn out of the University of Maryland did a wonderful piece on this. Every country in the world, and we have data from every country except North Korea, you need a medical licensure to practice in that country. And how is it that we allow short-term engagements to occur without that medical licensure? And over the past few years, particularly in the pre-COVID days, there were more and more physicians being prosecuted for practicing without a license. A Canadian being arrested in Ethiopia, an Australian being arrested in Nepal, a surgeon out of the US having a malpractice case against him in Nicaragua. I would say it's high time that this happened, right? The other important thing that we have to keep in mind, and just brought up the point about the premise of global health, we know that clinical care contributes to about 10% of the overall health of a community. And I'm a clinician. I'm not trying to minimize it. Clinical care is an important 10%, but it's only about 10% of the overall health. And our global health activities tends to hyperinflate the primacy of clinical care in the overall health of a community. And obviously, if you're sending learners and they're not brought in a good model of learning, there are huge pedagogical concerns too. Next slide, please. I'd like to bring up something called the Brochet Declaration that I've been intimately involved with. A group of us got together in Washington, D.C. at the sidelines of a CUGH, Consortium of Universities of Global Health Conference, and kept asking this question: how is it that we can come up with some guidelines, principles for short-term engagements in global health? And the long story short, we came up with the 6 principles that has now been signed by multiple agencies from around the US and around the world. And that's led to the formation of this organization we call the Advocacy for Global Health Partnerships, which is currently anchored at the Uganda National Academy of Sciences. The principles: the first one is about mutual partnership and bi-directional input, not a top-down, not a deficit-based approach, that the host country determines what the needs and activities are, and that the programs are sustainable and aim towards overall capacity building. I know some people don't like the term capacity building. I think it should be capacity building for all of us. Next slide, please. Continuation of those principles. There is a strong compliance with the locally applicable laws. We achieve the highest ethical standards and code of conduct. Humility, cultural sensitivity, and respect for all involved should be a part of this. And there should be an evaluation and an accountability for the actions that we do. These are the 6 principles of the Brochet Declaration. The WHO is very interested in it. They've asked us a question: shouldn't this go beyond short-term engagements, which I think we should. And the first feedback we got was, principle number 5 should be principle number 1, that we should approach this with a great degree of humility and cultural sensitivity and respect for all involved, rather than the sometimes arrogant way in which we have approached this. Next slide, please. Over to you, Jess. Thank you.
Thank you so much. We are going to have questions and comments at the end, so I'm excited for that. I just want to kind of put side by side the contemporary understanding of things versus outdated notions. When we look at our admissions committees and how we're thinking about students who have had these activities, oftentimes we're not oriented into the more current day practice. So outdated notion assumptions were that poor locations internationally were lacking the know-how to solve problems and need outsiders to help them or show them how to do things. Our more contemporary understanding is that local professionals and leaders in resource-constrained environments have the know-how to address issues, and that outsiders are often limited in their understanding of issues and solutions. Timeline solutions, outdated notion that this happens quick, that you can just parachute in and out and fix things. Newer notion that solutions happen over long timelines are the result of formal, continuous, locally led, and accountable efforts. The outdated notion that pre-med students should jump in and take care of patients, and that doing things that they're not allowed to do in the US is celebrated and exciting, and the focus on doing. Contemporary understanding is that pre-med students should not practice hands-on clinical care. They should not be doing pharmacy operations or other illegal, unethical activities. And if they can't do it here, they can't do it there. And even if they can do it in the US, let's say they have an EMT license in the US, does not mean that they are licensed to do it there. And that pre-med students and pre-health students should focus on learning and realize that there's a stepping stone process to becoming an agent in their own settings and settings anywhere. And the focus of the experience, outdated, was that pre-med students should focus on clinical care to understand medicine and health. More contemporary understanding is that pre-med students should focus on learning about social determinants of health, sustainable health systems, evidence-based interventions, the SDGs, cultural humility, and the intersections of public health, socioeconomic status, health, and healthcare. There's a lot of desirable qualities of our students that can be developed when they participate in appropriate programming. They can develop sociocultural humility, a service orientation. Again, service orientation does not mean short-term clinical service. Resilience and adaptability, critical thinking, ethical responsibility, self-awareness and capacity for improvement, and a deep understanding of medicine. As you are doing your admissions committee work or your advisor work, you are likely to encounter 3 different realities. So number 1, you will encounter students who will participate in well-designed, appropriately scoped, authentic experiences and speak of them as such. Or you will encounter students who will participate in poorly designed, inappropriate experiences and demonstrate post-experience critical thinking, insight, and reflection, and even regret. Or thirdly, you will encounter students who participate in poorly designed, inappropriate experiences and do not demonstrate insight or reflection into the inauthenticity and the problems with them. So I want to introduce Tricia Todd from the University of Minnesota, who you heard from earlier, to talk about their amazing work.
Thank you, Jess. So as I mentioned, I'm the director of the Pre-Health Student Resource Center on our campus. We have been on our campus for 22 years. And that gives us a lot of experience with pre-health students. And I've learned a lot in those years. So on the next slide, you can see the variety of activities that we are involved with. We do everything from career exploration courses. We actually create and run global programs in collaboration with our Learning Abroad Center. We do a lot of meeting with students, so we learn a lot. Every time we are working with students, we're learning about what motivates them, what drives them, where they're what their hopes are. And we've learned to reframe even the way we talk about things from, 10 years ago to now, as far as preparation to become a good pre-health student and a high quality applicant. So on the next slide, you'll see that so I should probably mention that I come from a background working as a public health professional for a number of years before I came to the university. And public health has a principle that we let the community lead. And so early on, back in 2008, I was reviewing personal statements from students applying to a health profession program. And I would read things like the stories we talked about, as I went to another country and I was doing all these medically related things. And the first question I had was, this doesn't seem right. And I started asking various different people on this campus saying, is this okay? Do we see this as an okay thing for students to be doing? So then I reached out to our Learning Abroad Center and we pulled together a group of physicians from our medical school. And we had a big conversation about this, only to learn that even the physicians in our medical school at that time were saying, that doesn't seem right. These are untrained individuals going abroad. Out of that came the idea to create an online module, which was called the Global Ambassadors for Patient Safety, and to train our students around what is appropriate and not appropriate. And at that point, I thought, oh, good, that's all it's going to take. Well, that wasn't all it took. So then I started working with folks from the Forum on Education Abroad, and that's where I actually met up with Dr. Evert, and we came together to say, well, we'll just create some standards, and that will help all those organizations out there that are doing these kinds of things know that they shouldn't be doing these kinds of things. And once again, oh, yep, we're going to be done. Well, no, we weren't done. So then we had to create some policies on our campus, and a couple of the policies that we created were that all of our students that were going abroad needed to complete the Global Ambassadors for Patient Safety, and they would get an oath, if possible, in the language of the country they were going to, that they could share with the folks on the ground and say, I am not qualified to be doing this kind of work. Because part of what we learned is that the folks on the ground didn't always know the level of training that these students had. And there were assumptions that when they referred to themselves as pre-health, that to them sounded like they were in a health profession program, but they weren't licensed yet, but they were still in a learning environment for becoming a health professional. So we created some online toolkit for some of our advisors to be able to work with students. We hosted Ethics of Health conference to try and get at this idea of why is it that people feel so motivated to help even if they're not qualified to. And we learned that we had done a great job of kind of some of the basics around our students going abroad through a formal program, training our advisors, training other people that needed to be trained. But then we realized we had this group of people that were part of what we called student organizations on campus. And the student organizations on campus were not governed the same way. And we often had no control over those organizations. And the University of Minnesota saw itself as not responsible for them. If they were just a registered organization, we're not really responsible for them. So we argued long and hard. And as a result of that, we actually came up with a registered student organization health activities agreement form that I will show you in a bit. It was a reprieve during the pandemic. I hate to say that, but it was kind of a reprieve to not have people going abroad. And we thought, oh, good, we'll keep working on some of these things and maybe we'll be able to move the needle on this. But then global travel reopened and things did not change. So on the next slide, what we have learned is there are organizations that are out there that make money, make lots of money by identifying students on campuses. And there's a lot of campuses on this, in this country. And they identify students and they might find one student and they say, if you start a chapter on your campus and you get X number of students involved that are willing to go abroad, we'll send you for free. But don't tell anyone what you're doing because we know that they say you're not supposed to do this. So on the next slide, this was an email I received just 2 months ago. An organization that has been trying long and hard to open a chapter on this campus continues to do so. I have dealt with this organization for years, and then this last year and this year, I had students reach out to me and say, we want to become a chapter. And I said, nope, not on this campus, and I'll tell you why. And on the next slide, you'll see the document that we now require all of our registered student organizations, whether they are undergrad or health profession, to sign saying they will not perform these activities. This was a document that was created by the associate deans in our health science schools. Because when we brought this to them and said, we don't think these organizations should be involved in these activities, they came up with this list. And you can see there's a few places where it says, but not limited to. So, and this is reviewed every year. Dr. Brian Sick, who is my boss, and I review every application to become a registered student organization, and we require them to sign this. Now, is this a legal document that's going to actually hold up in a court of law if a group of students go abroad? Probably not. But it at least gives us something that we can say we've been doing, and it does educate the students, because as they've had to sign this, I have had students contact me and say, wait a minute, so if I want to go do this, we can't do this? Nope, you can't. And so it has helped a little bit. All right, and on the next slide, the other thing I want to mention is, as a result of this, and Dr. Prasad was the original designer with me of our Health and Medicine in India program, we have created a number of programs and continue to create them that are designed to be the kinds of programs that Dr. Evert talked about earlier, that are really focused on the things that we want students to learn. We want students to go into other countries and recognize what they're doing well. We don't want them going with an attitude that, oh, we're gonna show them what we do. And really, it has worked. Our evaluations have consistently come back showing that students have been very amazed and very impressed by the work that's being done in other countries. So I think we're doing it right with our global programming. I hope we can continue to grow it over the years, and I've continued to share this with a lot of other universities so that they can build their own programs that are like this. And on the next slide, I just want to mention finally that Global Ambassadors for Patient Safety online workshop that we created is being used not only in this country, but it's being used all over the world. So we have some programs in other parts of the world that have actually adopted it to help the students that are coming in from other universities and from other places in the world to take this workshop and learn about the expectations that they should be adhering to when they are in these other countries. We have had advisors from other universities here contact me after their students return saying, wow, I had no idea. And so the advisors have reached out to us and said, can we use this on our campus? And it's absolutely, please do, because it's a lot of education that needs to go into place for the future. And we continue to try and do that with our campus and share that with other campuses around the world. So I think that's it for me.
Thanks, Tricia. And it is open access, so anyone who wants to use it. And I really just want to commend you for framing this as a patient safety issue. I think the more we can frame it in ways that students are excited about, the better. So when thinking about admissions committees, and we would love to, let's chat about this, but some of the things that come to mind for us that admissions committees can do is, number one, ensure that your website is clear about what type of clinical exposure is appropriate. Being vague can really lead to misinterpretation. And many admissions committees are actually reviewing their web content to say, do we need to be really explicit about not taking advantage of patients internationally or in resource-deprived settings in our own backyard to get hands-on clinical experience. Equip your admissions committee and staff with the knowledge and processes to appropriately weigh and discuss international experiences. Even just naming this as an issue is so important and helpful. Also, looking for appropriate competency development. So as you have students applying in their application or in their interview process, really look for appropriate competencies, not a sense of hubris and superiority and racism and colonialism. And so getting beyond that is really important. Avoid celebrating illegal, unethical, or unsafe activities during your application process and onboard admissions committees to these practices. and getting to know other stakeholders on campus. I mean, I think what Tricia's work shows us is that there's a lot of stakeholders on campus that may be interested in this from other lenses. And so really collaborating across campus. But we want to take the last few minutes for questions and comments. Please feel free to unmute yourself or put questions and comments in the chat.
So while everyone else is thinking, I want to share that Dr. Evert and I presented to the University of Minnesota Admissions Committee a couple weeks ago. And I was very pleasantly surprised to hear how strongly they endorse much of what we're saying. And because that was not always the case a number of years ago. But I think as we have, and I probably can't say this the right way, but I think as we see new blood coming onto the admissions committee, and especially as that is younger physicians, I think that is bringing greater awareness. And I am so excited to see that happening, because I think that is really going to help us move the needle on this, is if we can get our admissions committees to recognize and endorse the fact that we don't want our students, our pre-health students, going abroad and doing these things.
What are some reflections that anyone's having or things that are coming up when you think about your own experience and positionality?
Hi there. I just want to first thank you guys. This is excellent. This is actually the second time I've heard you guys speak, and I wanted to hear it again to take notes this time. I'm at Wayne State in Detroit, and I feel I'm kind of swimming upstream. I'm one of the first kind of global health physicians in a while. And so I found, me beating this kind of same drum has only gotten me so far. So unfortunately, I had to join the faculty senate and do other things, I think just to kind of get my myself positioned a little bit better to make a better impact. So, I'm going to kind of chip away here at my university. But I hope that your examples, like we now use GAPS for all of our global health students in the concentration, and I recommend it to every kind of student resident that is interested. But like at the AAMC level or at CORD or some of the other bigger, sorry, I've got a toddler with me. Are there any ways, like I'll do my grassroots at my university, but just kind of the top-down approach. I applaud everything you're doing. Thank you so much.
Dr. Kaufman, a quick note here, and I think you bring up a couple of very important points. We've always known that approaching from the ethical lens sometimes takes time. Like, how do you make good behavior socialized into people's everyday activities, right? And it's been fascinating because, and this is one of the reasons I really like the GAPS module, because Tricia's been very careful about the wording. It comes from a safety lens, not from esoteric ethical principles, right? So it's a very pragmatic, very practical, people can respond to it kind of a model, right? And on the flip side, we always say that ethics and the legal sides are two sides of the coin, right? Ethics is appealing to the good side, the legal side is legal side, regulations, et cetera, are appealing to the punitive or structural ways of doing things. So I think both need to happen. And we are hoping for a day when ethical behavior is socialized so well in our admissions committee, in our practice in global health, that it won't be a problem. But yeah, acknowledge what you're pointing out. It needs to come from the top too.
Yeah, and I think post-COVID, we're all relaunching reality, right? And I think there's an opportunity because the AAMC and NAAHP and other groups were kind of more, I think this was more in focus pre-COVID. And so I do think it's important. And Tricia, I wonder your thoughts on it too, like to kind of renew these efforts within those larger organizations. There's been a lot of turnover of team members, and I wonder, Tricia, your vision or thoughts on how to engage or our need to engage those organizations.
Well, then I'll just add another piece to this too, though, that I think is kind of important. As we were the epicenter for the George Floyd killing, I think there's a greater thirst among our students for social justice. And I think that we have to start framing some of this from a social justice and equity lens, because I think they will get on board much quicker. I mean, many of us, ourselves included, are having a protest on campus today because of what's happening in, Israel and Gaza. And that's the kind of active engagement that we want to see from our students, really focusing on what's just and equitable around the world. And so I think that's an opportunity that we have that we should be figuring out how to harness. This is a time when I think we could take this to students and to other organizations and really emphasize this in a social justice and equity lens. I know that doesn't probably answer your question, but that's kind of my vision for the future.
Yeah, and I think there used to be this notion that, oh, well, we all have to make mistakes in order to learn. And 20 years ago when we were talking about this stuff, it was like, well, we all had to do that and we all went through that. And I think at some point we just have to say, no, actually, we don't need to make mistakes to learn. And it's not okay to make mistakes on, Black, Brown, Indigenous women, children, minoritized groups. And I do think that aligns with the wider societal consciousness in this way. And I also think there's more emphasis than ever for medical schools for students to have clinical experience, and that clarity. And Adam brought it up in the comments around how medical schools can be clear on what experiences they're looking for and what experiences are not helpful. I think all the better, because that's a huge stakeholder in this dynamic, as well as students who have these realizations early. I mean, there's this inverse proportionality between your level of experience and your humility in healthcare. And the farther I get along in my career as a clinician, I'm a hospitalist and a palliative care doc. The farther I get along in my career, the more humble I get about what I can do and the complexities of helping people. And so it's that naivete and that ignorance that we have early on, or even at pre-med undergraduate levels, that are being exploited. And so if somehow that wiseness and that insight could be moved front-loaded in some ways through other lenses, maybe it's social justice, maybe it's other lenses, I think all the more helpful. As we close, I just want to say that, we did do a session with University of Minnesota's admissions committees, and we're super happy to help individual admissions committees or medical schools or pre-health advisor groups grapple with this and talk through it. So reach out. Tricia and I's emails are in the chat. Thanks everyone for caring about this, and please be in touch.